So essentially, what Julene and I are going to talk to you all about today is fetal alcohol spectrum disorders prevention. And I want to thank you all for allowing us to present. This is on behalf of the FASD Champion Network through the American College of OBGYN. I do not have any financial relationships and serve in this role as in a volunteer basis. So I just want to give a disclaimer as we go through anything specifically focusing on pregnancy that OBGYN, we recognize parts of this presentation as well default to gendered language because that is what often is the only language that we have. But I do want to take a time to acknowledge that the term woman doesn't necessarily include all people who can get pregnant. And I will, as best possible, utilize patient-centered or person-centered languages as well as inclusive language when possible. So today I just want to go over an overview of fetal alcohol spectrum disorders, kind of talk about the incidence and prevalence of FASDs. I know that those of you who were able to attend our journal club last month will have some familiarity with that already. We'll talk a little bit about alcohol use amongst birthing people and then just recommended screening and brief intervention techniques, many of which will be very familiar to all of you in your role in addiction medicine already. So I just want to go over, I think it's, I really think that history is important when we're looking at the context of things. And actually, the term FAS or fetal alcohol syndrome was first coined in 1973 at the University of Washington. And actually in the 70s and 80s, ethanol was used as a tocolytic to delay preterm labor. So if you talk to any, you know, more seasoned nurses or OBGYNs, many of whom are retired now, but you do have the opportunity to kind of gain some real insight into what it was like when this was used for a tocolytic for preterm labor. Fortunately, it was found that it did not perform better than placebo, and this was stopped in the 80s. And actually, in the early 1980s, the Surgeon General issued an advisory against drinking during pregnancy, and this was upheld and expanded on in the early 2000s as well. So what are fetal alcohol spectrum disorders? So they are a range of effects that can occur in an individual exposed to alcohol during the prenatal period. So that's really the connection, is you identify something in an individual and there was prenatal alcohol exposure as well. So these effects can be physical, mental, behavioral, learning disabilities, and they can have lifelong implications. But I think what's important to know is this term fetal alcohol spectrum disorder, although we use it as a group, it's really not intended as a clinical diagnosis. And here are the clinical diagnoses that fall under the umbrella of FASD. So we have fetal alcohol syndrome. That's the classic one that many of us learned about in medical school. But more often and in more individuals, you'll see these other diagnoses: partial fetal alcohol syndrome, neurobehavioral disorder associated with prenatal alcohol exposure, alcohol-related neurodevelopmental disorder, and we can also see alcohol-related birth defects. One example is cardiac defects are seen at a higher rate in those with prenatal alcohol exposure. So what causes FASD? So really the only etiology is fetal exposure to alcohol during pregnancy, and we know that alcohol can be a teratogen, which means it can interfere with normal fetal development and can cause birth defects, among other things. And as we talked about in the journal club that I was able to do with the addiction medicine team there last month, we know that prenatal alcohol use is the leading preventable cause of birth defects, developmental disabilities, and learning disabilities. And I think to contextualize that, we know that the majority of birth defects are not preventable, but this is one of those where we could have the ability to intervene. And I think what's especially important is most fetal alcohol spectrum disorders are not visible and they can't be diagnosed at birth. So it's not simply looking at a baby at the time of delivery necessarily, although sometimes, and being able to say, okay, this individual will not be affected. This is a really nice image to kind of show us that, the human body is developing across gestation. And in particular, when we look at that top line, the navy, the brain and spinal cord are developing from the 5th week, and really up until age 25, the brain continues to mature. So certainly throughout pregnancy, there isn't one time where alcohol would necessarily be, quote unquote, safer. And I think here's that most important data, that up to 1 in 20 US school children may have some variant of fetal alcohol spectrum disorders, one of those 5 disorders that we talked about a little earlier. And something that's really important to consider is the overlap between FASD and autism spectrum disorder. So you can see that there are sort of 4 criteria that are more unique to prenatal alcohol exposure, but there is a lot of overlap. And so certainly when you're evaluating someone, if you're a pediatrician or family medicine or working in developmental childcare, it's important to make sure that you talk about exposure, because that may have different, it may mean different things for how you care for that child. And I think the important thing, and we'll contrast this a little later with opioid use disorder, and its effects on infants, is that this is really a lifelong potential diagnosis. There's no cure, but we do know that early intervention treatment services can improve development, and so I think that kind of highlights the importance when we're evaluating children who might be at risk of autism spectrum disorder to also ask about alcohol spectrum disorder, because there may be different interventions that we're going to utilize for those folks. And I think it's also important to know that we can't predict based on a prior pregnancy, or even for two babies in the same pregnancy, what the effects of alcohol exposure might be. So there was a very nice twin study that looked at identical alcohol exposure, because it's one pregnant or birthing person and two twins, that they didn't have the same phenotype or development after delivery. And so we really don't have a way to say this individual is more or less likely to have effects from prenatal alcohol exposure. And we know that living in Wisconsin, where I live in Minnesota, and really across the United States, alcohol is very ubiquitous in our society. And there are more than 3 million US individuals who are at risk of an alcohol exposed pregnancy. So that would be individuals who have the potential to become pregnant, who are within that childbearing age. And when we survey those individuals who could become pregnant, 3 in 4 who wanted to get pregnant as soon as possible also reported ongoing alcohol consumption. And this is just kind of looking at not only alcohol consumption prior to pregnancy or when people are trying to become pregnant, but among pregnant women. And so this is a recent study that was published by the CDC, looking at, people's identified exposure during pregnancy. And 1 in 9 pregnant people reported alcohol use. And of those who reported alcohol, 1 in 3 reported binge drinking. So 4 or more drinks on one occasion in the past 30 days. So we know from ACOG, what we sort of are trained to say is that there's no known safe amount, no safe time, and no safe type of alcohol during pregnancy. And really, zero exposure is zero risk. So we know that beer and wine are just as harmful as hard liquor. Often now we'll hear of people saying, well, I just drink hard seltzer, or hard tea, and those are just as potentially problematic. And that in particular, when we're looking at harm reduction, which is obviously a big part of what all of us do in decreasing risk, that binge drinking can be particularly harmful, because you've got that high concentration of alcohol waiting to be broken down by the pregnant person's liver, and it's going to diffuse from a high concentration to low concentration. So this isn't saying that any exposure is okay, but in particular, the problematic binge high concentrations in short periods of time is something we need to pay attention to and screen for. And I just brought these up. I mean, if any of you go on the internet on any given day, you'll see so many situations in which alcohol is normalized. So these are just sort of 3 that I pulled within a couple of minutes, talking about how it is frustrating to not be able to consume alcohol during pregnancy, that this is the true sacrifice of a pregnant person. And we also look at the intersection for some individuals between alcohol and other substance use. Again, for those of us in addiction medicine, this is particularly important. So if you identify a pregnant person who has reported consuming alcohol in the last 30 days, asking about other substances, tobacco, opioids, benzodiazepines, everything that we would typically screen for. And then really I talk a little bit about alcohol use when breastfeeding, because depending on what study you look at and which country that study was done, somewhere between 36 and 83% of breastfeeding folks identify alcohol consumption. And we know that alcohol passes freely into breast milk. So the levels in breast milk are comparable to those in a breastfeeding person's blood, with a peak after 30 to 60 minutes. Again, pretty similar to alcohol in the person who's consuming it. Alcohol from one drink can be detected in breast milk for about 2 to 3 hours. So when we're thinking again about harm reduction, when people should be breastfeeding or when they should be pumping breast milk after consumption of alcohol. And we know that the more drinks that someone consumes, the longer that alcohol is going to stay in the breast milk, because you're waiting for that metabolism to be undertaken. So the more drinks, that longer time period. And when we look at the newborn, we know that they tend to have delayed alcohol metabolism. So it's typically 25 to 50% of the rate that's observed in adults. So the blood alcohol level in a nursing infant is going to depend both on the amount of alcohol in the milk, which is going to depend on the amount consumed by the breastfeeding person, and on the infant's metabolic capacity, which can range from baby to baby. And there are data to suggest that infant exposure to alcohol through breast milk in higher levels may cause cognitive abilities as well. Again, we talked about the brain and its ongoing growth well into adulthood, and so that alcohol exposure can certainly be an issue for that newborn as well. So the recommendations from the American Academy of Pediatrics are pretty clear. So they really recommend minimizing ingestion of alcoholic beverages and really limiting it to occasional intake, no more than 5 grams of alcohol per kilogram per body weight. And really the most important is to avoid nursing infants for at least 2 hours after alcohol consumption. I would go a step further and say 2 hours after one drink to allow it to be cleared from the breast milk. And again, this same normalization of, the sacrifice of abstaining from alcohol in pregnancy is also seen during breastfeeding and during parenting, that, there's something about parenting that requires significant alcohol consumption. And so it's just important to kind of pay attention to what our patients are seeing in the media. My particular passion for years has been perinatal opioid use disorder, breaking down stigma and accessing treatment. So I always like to contrast this with opioid use disorder, which we talk about a lot for our pregnant folks. And when you contextualize that with alcohol use during pregnancy, I think it's very interesting to put these side by side. So opioid use is 1.6 to maybe 8.5% of pregnant people. Alcohol use consistently, the most recent data say a very similar rate of that higher bracket of percentile for opioid use. NAS or NOWS, the constellation of symptoms we see after prenatal opioid exposure, is seen in about 30 to 80% of infants exposed to opioids, whereas 1 to 5% of total school-age children may experience an FASD. And I think most interesting is that in general, neonatal opioid withdrawal syndrome, we believe, has sort of a limited timeline, whereas fetal alcohol spectrum disorders may be much more long-lasting. Again, just looking at the cost, so the average cost to care for an individual neonate experiencing opioid withdrawal is about $90,000, mostly for that inpatient stay, whereas caring for an individual affected by fetal alcohol spectrum disorders can be upwards of 1.2 to 2.5 million over the course of the lifespan. And then these are just sort of the kind of things we always think about as far as the care, which I think all of you are very familiar with. So what is low risk drinking and what is heavy or at risk drinking? So low risk is not no risk, but in general, women and people over 65 are advised to have no more than 3 drinks in a day and 7 drinks per week, although this may change depending on an individual's health and alcohol's individual effects on them. And what we define as heavy or at-risk drinking is more than 4 drinks in a day for men, more than 3 drinks in a day for women and people over 65, and always thinking about the risk of alcohol use disorder in these individuals. I just put this in. I think you learn all of this and it's on your boards for those of you who are taking the addiction medicine boards, what the standard drinks are and what that alcohol content is. So I always like to put those in just for reference. I think what's most important for those who are caring for pregnant folks, those of us in OBGYN and family medicine, is really asking, using effective screening tools, which you're all familiar with, although those may be a little different in pregnancy because we tend to want them to be validated in pregnancy. But really all of this stuff should be a routine part of prenatal care, just the standard questions you ask every individual who comes in. And brief interventions really can work, including in pregnancy. So this is an older study, but the most recent time that all ACOG fellows, so that is board certified members of ACOG or OBGYNs working in the United States, 22% did not recommend abstinence. 58% did not use a validated screening tool to objectively look for alcohol exposure. And over a quarter did not feel prepared to screen patients. So probably some of the reasons some of them weren't screening. And I will say we see this in a lot of surveys or inquiries looking at substance use, is that in general, those who are providing prenatal care do not necessarily get that training that they need to go out with confidence and screen, identify patients with at-risk use and refer them for treatment. However, when we look at women, and again, those of you who went to our journal club will be very familiar with this data, when they asked women, including pregnant people who had identified substance use, 97% said, you know, it's okay for my providers to screen me for alcohol use at a prenatal visit. And almost 100% of them said they would disclose that alcohol use if screened. And this is including individuals who said, I have consumed alcohol during pregnancy. So I think it's important to know that a lot of us are scared to ask because patients might feel judged. But at least in this study, patients are indicating that they would feel comfortable and that it's appropriate for us to ask those questions. Again, I think you're all familiar with SBIRT. It's something that we pay a lot of attention to in OB because in those short visits, you really want to have a quick screen that you can do maybe in the waiting room, maybe while the patient is waiting for the physician or the midwife to come in and take care of them. A really brief intervention just saying, you know, are you aware of some of the risks of alcohol in pregnancy? Because often that information is not conveyed. And then referring those for treatment in cases where it might be appropriate. And really what we are trying to do is to focus on this 20% of at-risk drinkers. So you've got sort of abstainers and low risk, which are not the folks that we're focusing on. It's really this harmful and hazardous in the yellow and orange, where brief interventions may be very effective. You know, individuals who have what we would identify as at-risk levels, but may not have an alcohol use disorder. Now, this intervention will also identify those who might need additional treatment later. What are those interventions? We know that finding people to administer interventions to, we're going to do our best if we are screening with a standard validated instrument. So in pregnancy, we typically use the CAGE aid tool or the audit. So there are several tools. These are specifically for alcohol. We also use some, I tend to use the 4Ps plus or the 5Ps just to have more of a standardized full spectrum substance use screen. And then I follow up with individual substance use questions. And this is really easy to integrate with appropriate planning into a clinic. There's a lot of downtime when patients are waiting. They're waiting after their ultrasound. They're waiting for the doctor to come in. They're waiting for the midwife to come in where you can do this screening on an iPad on a piece of paper or have someone in your staff do that screening for you. These are just the handouts that we recommend that all of our OBGYN trainees have. So this is just, you know, really nice giving you the audit C. So it's a really quick tool to use. And then using motivational interviewing. Motivational interviewing has really been a game changer for me in my care because you're really building a team with the patient and saying, you know, are you open to talking about this? You know, are you aware of some of the risks? And then if they are open to talking, you know, kind of going over these towards types of things, you know, what do you like about drinking? Or it sounds like you're not ready to stop drinking. What would need to happen for you to feel comfortable taking that next step? What would a change look like for you to cut down on your alcohol consumption? And so I think this has been really helpful. We're not only talking about alcohol, but substance use, exercise, dietary changes. Motivational interviewing is just really a great tool. And I definitely recommend utilizing that in your practice, which I'm sure a lot of you are with your focus on addiction medicine already. And I think we all know this, but I always like to put this in for those who may not be as familiar or kind of new to this work is that, you know, motivational interviewing is really getting the change from the patient and not you telling them what you think is going to work for them. They know where they are in their readiness. They know where they are in their ambivalence. They know what realistically can happen next and not us saying you need to stop drinking by the next time I see you when the patient knows that they're just not at the place where that can happen yet. But this never is a situation which you're telling the patient that they have a problem and telling them they need to change. Like you as a power position saying you have this and you need to do this. It's really getting to know that person and what resources they have available to change. This is just another, you know, just kind of talking about this. This also highlights something that we talk about a lot with our patients is this should be universal screening. So it isn't just when a person is pregnant, but if somebody is coming in for preventative health care and they have the potential of becoming pregnant, I say to them, you know, what are your plans for the next year? Are you considering pregnancy in the next year? If they say no, we talk about, you know, contraception and a lot of other health choices. And if we say, you know, I actually am considering pregnancy, we talk about healthy lifestyle, substance exposure. There's just a lot of important things that you can do, but that starts with sort of asking that person what their life plan is for at least the next year. There's some great work that's been done out west with the one key question, which essentially is asking patients if they intend on becoming pregnant in the next year. So I think, especially when you're working in an addiction medicine clinic where a lot of our folks may not have access to contraception if they want it, or it just may not be at the place where they're thinking about planning a pregnancy, asking that kind of question can be really helpful. And then referring them to gynecology for contraception if it's something that they're interested in is important as well. So I want to talk, kind of quickly about the treatment that we use for alcohol intoxication and alcohol withdrawal in pregnancy. This isn't particularly different than what we would do in the non-pregnant people. I think the most important thing that we wouldn't necessarily do in pregnancy is when they come in with acute intoxication, making sure you're giving that thiamine. Again, those of you taking care of non-pregnant folks are going to be very familiar with this. Then some IV glucose, and then supplementing those vitamins for several weeks if possible. We do utilize short-acting benzodiazepines. Those are very safe in pregnancy for acute agitation. Haldol can be used as a last resort, but because it can be synergistic with alcohol, we tend to avoid that. And I think for any patient that's coming in who's identified as pregnant with alcohol intoxication, using that expert, doing some screening, considering some motivational interviewing with them can be extremely helpful because they may not be interacting with the health system that frequently. And these are just some of the issues related to treatment of alcohol use disorder during pregnancy. This is not something that someone who primarily provides OB care should necessarily be doing in a vacuum. So I always recommend a partnership with the addiction specialty teams. In our system, we have an addiction medicine inpatient team, and that's where the patient would be cared for. And then the obstetricians or maternal fetal medicine would serve as consultants, just making sure those meds are sort of compatible with pregnancy, but in general, the benefits likely outweigh the risks based on the known risks of no treatment and ongoing alcohol exposure. So I think you're all familiar, or you will be, and this is all on the boards as well, kind of that acute detoxification period. That first 24 hours is kind of key for alcohol withdrawal. And of course, we need to watch in those folks who are at risk for delirium tremens in the days to follow. Again, benzodiazepines, although they have been formerly an FDA pregnancy category D, we use benzos in a short course for acute detoxification. Phenobarb is also compatible with pregnancy. And then as soon as patients are stabilized doing that taper, there are a lot of different protocols for benzodiazepines for treatment of alcohol detoxification, and I am not aware at this time of any literature that shows that one of those, kind of the lower dose or symptomatic treatment or just sort of scheduled treatment, is more or less beneficial in pregnancy. So I would really use whichever one you feel comfortable with in consultation with your obstetric team. There is also the use of naltrexone as ongoing treatment, and certainly that's something that we talk a lot about using for opioid use disorder in pregnancy as well. It's a relatively new treatment in pregnancy, but certainly weighing the benefits and risks of treatment versus not, I certainly would support naltrexone in pregnancy. The biggest concern with naltrexone, because of the way that it works as an opioid blocker, is there can be problems with pain management at the time of delivery. So some folks will wean or kind of taper their patients off of naltrexone prior to delivery and have them have a consultation with a anesthesiologist beforehand if they're going to remain on that around delivery, just to help optimize pain control. I think, a lot of the focus today is the importance of trauma-informed care. And we know that there's a relationship between violence, trauma, and those individuals with alcohol exposure during pregnancy. And so I think that it's always important to pay attention to someone's history. There is a very high risk that that person has been exposed to some sort of abuse, that they have post-traumatic stress disorder, or have had intimate partner violence during their pregnancy or in childhood. And trauma-informed care is something that we really try to emphasize here in our addiction work. So really realizing how ubiquitous trauma is and the paths that people need for recovery, recognizing the symptoms in your patients. So it's not that they are a bad person, but what happened to them to have these sort of trauma responses, responding when you see these symptoms, and then really being careful of re-traumatizing individuals. So we talk a lot about triggers, especially surrounding pregnancy and childbirth, and then parenting. So if you have been in an environment where your parenting may have caused some trauma, how do you avoid kind of that generational trauma in the future? And I think something that is very similar with so much of the perinatal substance use care that we provide is the stigma. And that, there are data, and I think we all know in doing this work that individuals who had alcohol exposure during pregnancy will often experience judgmental attitudes from their, caretakers, feelings of shame or guilt, depression, low self-esteem, and then also fear of having their children removed from the home as well. And so we really need to work on reducing stigma, more patient-centered or person-centered language. Stigma prevents a lot of people from being as candid as they can with their healthcare providers. That's going to include pediatricians. So if individuals can't identify their exposure to pediatricians, how are we going to get the right interventions for those children when they're appropriate? And I think really being mindful of the language for those of us working in academic institutions, when we're training that next generation, being very careful about using things like alcoholic and using a person with alcohol use disorder, using prenatal alcohol exposure, kind of making it more that this is a condition and it doesn't define the person who's experienced it. And I think the more that we support this as a community, when we're talking with the media, when we're talking with trainees, the more we're going to be able to break down that stigma significantly. These are just some of the online resources for referral to treatment. I will say a really great program, if you haven't checked it out before, is the second one, which is the consultation warm line. So this is out of the University of California, San Francisco. This is during the work week and work hours, but they have a warm line for substance use management. So you can kind of call them. And it's not to say like, I need this for this particular patient, but this is sort of general advice, referrals, things that can be very helpful. And then there's also treatment locations. What I would recommend wherever you end up in your practice is really reaching out to those services that you see in the community and say, what resources do you have for pregnant people? It's pretty remarkable what you can find, but we're often so siloed when we're looking at substance use treatment. And so really making those connections in your community can be very helpful. For those folks who have had alcohol exposure during pregnancy and may have children that have experienced FASDs, there's also the Circle of Hope, which is a great resource as well. And ACOG has a lot of other resources which can be really helpful for both providers and patients alike. I just put these in because it's nice to know the codes. Often in obstetrics, people are worried about being able to bill for this, but you can bill for screening and treatment for your patients. These are some other resources that we have available. There are some great CDC trainings, which are all free, that I would definitely tell you to take a look at, specifically focused on alcohol exposure and perinatal alcohol use, and even just how you talk about it. These micro learnings are great. Just a short session on how do you talk about alcohol use with a patient. When you do it for the first time, it can be kind of uncomfortable, and learning to destigmatize that and become more comfortable and normalizing it as a part of our OB care. We've also got some on ethics, and these are not specific to OBGYNs. These are things that are accessible for all folks who are interested. Some of the governmental sites, you can check all of this out, and those are my references. So I'm just going to stop real quick for questions, and then I will turn it over to Julene after I answer any questions that you might have. All right, well, I will give you a little more time to think about your questions while Julene is presenting, and I will send it over to her.
All right, thank you very much. And I want to give a different perspective, and this is from a birth mother's perspective and what life ever after looks like, right? So I'm Julene Zizza. I happen to reside in Colorado Springs, Colorado. I was born and raised in Alaska, and just like the good doctor shared some images and talked about life in Minnesota, I will say that alcoholism can be found many, many places, and even in rural Alaska. So I am here through ACOG as a way to provide a balanced perspective of before, during, and after. So full disclosure is that I am a member of the Circle of Hope Birth Mothers, And we are simply a subpopulation of the world of alcoholism and treatment. And we, as individuals with the shared lived experience, we try to carry that message to other mothers and individuals who are needing support throughout the lifetime of their children. Sometimes it's easy to focus on the beginning of a child's life, but I can tell you as an educator in a public high school that, you know, public education goes through the first 21 years of life, but there's a potential of 80 years after. That also is an area. So I have no financial relationship. I will say that my personal story talks about sexual abuse and alcoholism. My goal is to talk about the ranges of outcomes, even with my different pregnancies, and also talk about the absence or the presence of universal screening, motivational interviewing, and then implicit bias and stigma. So these are my first two children. Chiara Maria is the girl, and then Gianfranco. And this is the picture perfect coordinating outfits. The children are smiling. They are happy. But this is all a facade. It is a complete facade that can be dressed up in a moment's notice, but really doesn't talk about the background of the trauma that my own children were experiencing. So this is a different look at my son, Gianfranco. So this picture is when he was 3 months old, and he was almost to 5 pounds by now. So he was a small child, full term, and he has many lifelong effects from my alcoholism, my substance use disorder, and me carrying the burden of generational trauma from my family of origin and transplanting my own biological children into that. So the negative influences leading up to my pregnancies. So as a child, I grew up with an intact family unit. My parents both college educated. My father, a trial attorney, so he went to graduate school. My mom was a high school Spanish teacher. But my dad enjoyed having sexual relations with the three of us girls. And so even though we were also picture perfect, going to church every Sunday, being part of the community, having foster children in our homes, all of these things, which look really good on paper, really bring to family dysfunction. And so I acquired an eating disorder to help cope with the sexual abuse going on. And then as I got into high school, I learned, and especially into college, that sticking your head in a toilet really impedes your abilities to be social. So I shifted that coping skill into alcoholism. Ultimately, I was involved with a college campus rape on my undergraduate private university, which my parents paid a lot of money for. So let's look at a little bit of what came about to bring me here to this moment and this day. My daughter, Chiara, she was a planned pregnancy. When I was 20 years old on my university campus, I met my future husband, and life was grand. And as he and I became a partnership, that was part of my transition from eating disorder to alcoholism. It was still the form of escape. It was still for me to cope with what I was bringing into that relationship. So I was married at age 23. We had a grand life planned. My husband, PhD mathematician, he professor of mathematics for many years. And when we planned this pregnancy, I was sure that that would be the one thing that would allow me to finally be able to stop drinking. And so we tried to have get pregnant. And I realized when I found out I was pregnant, I realized I could not stop drinking. And that is a horrible place to be in, because the reality is I could not stop. Even though I wanted this child, I wanted nothing more than to be a mother, because I believed that being a mother was really my call in life. So I procrastinated on sharing that I was pregnant. Over the pregnancy, I still consumed alcohol every day of the 40 weeks. I gained 40 pounds. If I had been interviewed and discussed about my pregnancy and my alcohol consumption, I would have already scored an 18. There's 3 questions, and it's a Likert scale from 1 to 6. Like, I was already maxing it out because I was binge drinking every day. I blacked out every day. I was drinking 14 servings per alcohol a night. Now, that may sound bad to those of you who are not alcoholics, but as alcoholics, the reason I know it is a disease is because it's a progression. I didn't start when I was 13 drinking 14 servings a night. But given time, I sure acquired the tolerance, the physiological tolerance and the need to do more. And so, unfortunately, when you are part of a couple that looks like everything has it together, a PhD mathematician and his wife coming to an OBGYN across the street from the university, you know, we played that picture just perfectly for the right questions not to be asked. And something that we forget with alcoholism, the family gets sick too. My husband did not intend to marry an alcoholic, but the truth of it is we grew sick together, not because he ever was an alcoholic, but because our normal became what's tolerated. And as my disease got worse, he still tolerated it because he didn't have his voice and I couldn't find a way out. So 3 years later, we planned our second child. We already had these names picked out when we got first married at age 23. I was now 30 years old, and I had already realized I could not stop 3 years earlier. But I did swear to myself I was not going to gain that much weight again because my eating disorder had kicked in. I only gained 11 pounds. My son at full term was 4 pounds, 8 ounces. So I really had not taken care of my body in so many other ways. At that point, I was consuming 33 servings a night. And I didn't drink all day, every day. I waited till like 4 o'clock, 5 o'clock in the evening, and then I consumed 33 servings. And I woke up the next day and I did it all again. The insanity of substance use disorder is so real and so hard to find your way out for all members of the family. So I ended up having 2 very different outcomes. My son happens to have the face which can reveal the disruption to his brain and its processing. The bottom line is, I had no business getting pregnant. It didn't matter that I was married. It didn't matter that I had the name picked out. It didn't matter that I had health care. And guess what? I am the norm of birth mothers. We tend to be white, educated. My idea of what a person like me would look like is not me. But here I am. And so if you have the same bias towards thinking that the patient in front of you isn't that person who might need your help, then we need to stop and have that right conversation. But that conversation never happened with me at perhaps the right time for my children. So let's talk about when an intervention would have been good. Now, I will say, I am a mandated reporter as a teacher. If I think something hokey is going on with a student, I have to report it. If they tell me something about trauma that's going on, or abuse, or neglect, it is my obligation to provide support. And yet none of my teachers ever took that step. When I went back to my 30th high school reunion, everybody was like, oh, Julene, you were so sick in high school. You were so sick. And yet nobody did anything. And that is sad. So let's look a little bit further beyond the education environment, because things were different then. When I went to my private university, and I did all the right things, I joined a sorority, I did community service, I volunteered time in classrooms. I did so much to do it right. But when I went to one fraternity party, there was a visitor on campus. He was from another university. And I was involved in a rape. Because I had such poor boundaries with men already, because I'd never developed those, being raped was just one more step in my sickness and my trauma. But when I went to the health center on campus, there were no questions asked about, why do you want to be on birth control? As a 20-year-old female, it was presumed normal that I would want to become sexually active, which was not my motivation. My motivation was, well, if this is really how men are and not just my dad, I've got to protect myself. So my mindset and my purpose were different. And so I was received as behaving normally when that conversation was never had. So I got on birth control when I was 20. Okay, at age 21, again, just a refill, no conversation about my mental health. I was not any healthier at age 20 than I was at age 27 when my daughter was born. I was sick that whole time. And what I would say is, anytime for any interaction, you are talking to an individual who is asking for birth control or asking questions or is coming to you as a medical professional, what can we do as a community of people in service? I consider myself a person of service. I am not a medical professional, but I will help you because I want to be here to service anybody in the audience about being honest about where I was and what someone like me needs. So the good doctor did mention that many individuals like myself with the shared lived experience of addiction during pregnancy, 95% of us were sexually abused. I wasn't physically abused, but there was neglect and the sexual abuse. I have mental health disorders. And now it seems to be the era when students can talk about their mental health. It is much more prevalent in conversations in a classroom, in a hallway. Social workers being hired to help these individuals prior to being involved in raising a family. So FASD United is just one of many resources. And the big thing that I needed, and I didn't even know, I needed treatment. And the irony is, my blinders of me, I look back and I think, you know, I knew I had an eating disorder and I put myself into treatment for an eating disorder clinic when I was 20. That was right before I was raped. I already knew I had some issues. And so I seeked out that place that I could find help for eating disorders. Now, eating disorders are like many substance abuse, very difficult, many facets. I did not even know that there was alcohol treatment centers. I didn't even know that. And that is amazing as an educated woman who works with individuals with disabilities, that I was not even aware of that. So what I do as a member of the community of birth mothers is every Thursday night, I get on to Zoom and we have communities of women who need support because they're either pregnant, realize they can't stop, because they're planning a pregnancy, or they consumed products during the pregnancy and now their child is struggling in school. We have women who then, when their child with an FASD turns 18 and starts getting in trouble with the law, like we support everyone at every phase and stage, because sometimes you just need to know that there is somebody out there walking the same journey. The don't ask, don't tell does not work. If someone as sick as me could play the part of normal, then we have got to ask more questions. I would hope that after hearing this information, that you would understand that sometimes your implicit bias, that you bring that lens of what that person is going to look like, what that partnership is going to look like, what that pregnancy looks like, is different. And I will tell you, as much as you should practice the motivational speaking that you do to your patient, you should also plan that if you are going to ask the question, you must expect a yes. Because if you are just reading off the card that we have sent you and you are like, okay, are you consuming alcohol? Are you doing this? Are you doing that? If you are not pausing and making that attempt to really find the truth, it is too easy to just pass it off as, of course, they're going to respond this way. And if they say yes, you must have an idea of what your next steps are. Your face will speak louder than your words. And if you don't have a planned step, then that individual who has now become vulnerable to you will then feel shame. And that shame does not leave. It does not leave. And I can say that medical professionals in all areas have this bias. I went to my neurologist recently and I have chronic migraines. And she's like, Julene, why do you think you struggle with so many headaches? I've been seeing her for 10 years. And clearly, she was not on her game that day. And I said, believe it or not, it is very stressful, even though I am sober, to raise an individual with fetal alcohol syndrome. And she looked at me and she said, oh, when did you adopt him? And she had been my clinician for over 10 years. And I am like, I am his biological mother. And she is like, I cannot believe that I just did that. This is an educated woman who I trust with my medical care. And in that moment, she had a learning moment. And maybe that will carry for the rest of her 30 plus years of practice. Now, stigma against alcoholics and people with substance abuse, I can tell you, it takes many different paths to get to a place of sanity and health. And when I happen to go to 12-step meetings, because that is one of many things I do for myself and for my sanity, is that when I share at a 12-step meeting, which is a room full of addicts and alcoholics who've all made mistakes, there are women who share, well, I've never been able to get sober except when I was pregnant, as if I am worse as a human being than them. I have friends who have been in jail, have DUIs, prison, felony records. And when you poll them, I am still lower status than them. Isn't that crazy? I was never in trouble with the law. I have no felony charges. I've never had a DUI. Doesn't mean I was caught. Doesn't mean I was driving safely. But if this is the treatment we get within our own community of addicts and alcoholics, you can imagine how troublesome it is for us to open our hearts and be honest with you as care providers. So what I would hope that you would get from this message of me today is that incarceration is not necessarily the right path. Removing the children from the home is not necessarily the right path. The first step of many steps is the screening, the brief intervention, treatment. Then, and only then, can we have the family get healthy. And it takes many different journeys for many different stories. For me, I never lost possession of my children. They are still with me today. And we have grown together as a family. But being punitive is not always the best route, even though it might be our first instinct. Let's talk briefly about stigma. 20 years ago, we were just talking about FASDs are caused by a woman. Again, that response that it's all on you, mother, woman, pregnant. But instead, how about we say FASDs can occur in an individual who is exposed? My son was exposed. My daughter was exposed. Another one, FASDs are completely preventable if a woman does not consume alcohol. Okay, how about this? Just a small shift. FASDs are preventable if a developing baby is not exposed. So these are my first two children. And there are many, many joys that have occurred in our life together. It has been challenging. There is anger, shame, even though I speak fairly open about it. But there are repercussions that have to be dealt with in a family. Their father had to get healthy as a father, as a partner, as a husband. We all have taken a journey, and one person can do a dance, but it's a whole lot easier when everybody is working on the same common goal. And so this is my son and I. 23 years into it, things are so much better, but we have so far to go. I work in the field of individuals with disabilities, and I will tell you that even within my school district, which is the biggest school district in Colorado Springs, there is bias and shame even within the special education world. That somehow being honest as a mother who is trying to get supports and structures in place to better help my children, in order to get those supports, I have to be honest. And yet, I have learned from my school district that there is still shame. I have had supervisors in my department say to me, well, the mother says that she drank and she says that she's sober, but can we really trust her? That is from a professional leading the charge in my district. And so do you think, as an individual who fights for the rights of people, do you feel like it is a safe place that I can say, I am a birth mother and my son has fetal alcohol syndrome? Oh no, there is a succinct boundary between my professional world at the school and my professional world of me and you right here together today. Because not every place is safe. I have learned that the hard way. And I want you to know my children have given me permission to talk about their life. When my daughter graduated from college and she was seeking employment, I had to shift what I said about her. Her name was not shared because I didn't want an employer to look at her and say, well, we found this on your mom's social media, so I don't think you're a good candidate, because she was prenatally exposed. Do you understand how the sobriety happened when my daughter was 2, and yet in shared with the wrong audience, it can be used against her? So I would encourage you to have the conversations, talk to each other. So many families are impacted by substance use disorder that I am just one of many voices, and we all have our own journeys. But I would hope that today is a different day for one individual that you provide a service to. Thank you for your time.
Thank you so much, Julene. Always such a pleasure to co-present with you. Um, I want to just open it up for questions for either of us. If anybody has it, I think Randy had to step off. I think had some work obligations. Any questions that we can answer for any of you today? If not, I really want to thank all of you for taking the time to attend today and share this information with your colleagues, with your learners, with your communities, so we can keep working to break down this stigma. And thank you again for your time. And thank you, Julene, so much for being here today.
Yep. Thank you for sharing the platform.
Always. All right, everybody, have a wonderful rest of your day. And we will hopefully cross paths again soon. Bye-bye.